Hello, this is part 6 of our systematic approach to ECGs. And in this part, we're going to talk about supraventricular tachycardias. So supraventricular tachycardia, or SVT, has also been known as paroxysmal supraventricular tachycardia, or PSVT. Paroxysmal has been dropped, though, in most nomenclature now, and so we just call it SVT. But SVT can be divided into two groups, and the groups are Atrioventricular nodal reentry tachycardia, or AVNRT, and Atrioventricular reentry tachycardia, or AVRT. And this one is then divided into narrow complex and wide complex. So the difference between these two is one happens within the AV node and the other occurs outside of the AV node. So let's take a look at AVNRT. So in AVNRT, there is a circular pattern of electrical activity that is occurring around or in the AV nodal area. This circular pattern then sends off electrical impulses that depolarize both the atria and the ventricle. Because it is in the AV node, when it is depolarizing the ventricle, it's using the usual electrical pathway, or the superhighways, the right and left bundle branches. And so what you would expect to see then is that you have this sort of finding on rhythm strip, or ECG. And what you'll see is a rate of about 150 beats per minute, or QRS complexes per minute, or above, up to 180, in that range. But it's not less than 150 the vast majority of time. There is a retrograde P wave being sent off, as we saw, but that P wave is actually hidden or buried in the QRS complex, so you do not see P waves in AVNRT. And the QRS complex, because it's using that normal electrical pathway, is narrow and not wide. Now, if you have an accessory atrioventricular pathway where electrical current activity or current can go past from the atria to the ventricle without going through the AV node, okay, that's called an accessory pathway. And that then is what leads to AVRT. So here you have your electrical activity starting in the SA node, but then that electrical activity going to the ventricle via two different mechanisms. It's going both via the normal AV node and then electrical pathway, and then also through your accessory pathway. So it's going to look like this. Now, what does that do to your findings on ECG and rhythm strip? So what you find on your ECG is that you have a short PR interval because there's not that compensatory pause in the AV node because of the accessory pathway. The other thing you find is that you have a slightly wide QRS and what's called a delta wave, or a slurred upslope of the QRS complex. And that's because that electrical activity came through the accessory pathway, and then the normal pathway took over as the electrical current went through the bundle branch. But that slurred component is the delta wave is the part where the electrical depolarization of the ventricle started via our accessory pathway. This is also known as Wolff Parkinson White, or WPW syndrome. So in AVRT, you can have a narrow complex where there is a circular electrical current going around, just like in AVNRT, but this is not confined to the AV nodal area. It's using the accessory pathway. And so in this case, it's narrow complex because the depolarization of the ventricle is happening via the normal electrical pathway, the right and left bundles. The atria is also being depolarized as well. What do we see then on our ECG or rhythm strip? Well, we're going to see a narrow QRS complex with a fast rate. So our rate is typically, again, greater than 150 up to 180 or even higher in children. There is a retrograde P, as we saw on our diagram, but it is hidden in the QRS. so we don't see P waves. And the QRS complex is narrow, as we said, because it's using the normal electrical pathway. Now you can also have AVRT, wide complex, as we said. The vast majority of SVT, or supraventricular tachycardias, are narrow complex. They're either AVNRT or AVRT narrow complex. But you can have AVRT wide complex as well. And here's how that occurs. You have your circular electrical activity going down the accessory pathway and then coming back up through the atrial node, the AV node. And what happens then is that the depolarization of the atria happens like it has been happening, but the depolarization of the ventricle is not using our normal electrical pathway. It's not using the left and right bundles. And so it's going to be a slow depolarization of that ventricle because it's not using our superhighways. And so consequently, our QRS complex is going to be wide. And here's what we would see on rhythm strip. You're going to have a fast rate again, greater than 150. You're going to have that wide QRS complex, often greater than 140 milliseconds. And you're going to treat these differently, and that's why it's important. Why do we treat these differently than narrow complex SVT? The reason is because in this case, with a significantly wide complex AVRT, it's very difficult or challenging to distinguish this from ventricular tachycardia. You have a wide complex tachycardia with a fast rate, and not treating this as ventricular tachycardia can put someone's life at risk. So most of the time, we're going to treat these differently because we're going to treat these as ventricular tachycardia, even if we're not sure and we think it's possibly AVRT wide complex. So in summary, AVNRT and AVRT make up the two different types of supraventricular tachycardias. They have rates that are fast, greater than 150. They have a regular rhythm, and the wide QRS complex AVRT is difficult to distinguish from ventricular tachycardia. And so if you can't easily distinguish it, you're going to treat it as ventricular tachycardia until proven otherwise. Thank you.